I am very thankful to be part of VRSI PAT survey team, which we did for 2 years. So we have around 1,200 VRSI members. Of that, around 200 people had responded to the question. So these are fairly questions which we would require in, day out of an answer. So it's already published in IGO. This is the reference. If you go and click on it, you would be able to get that. So these are questions for phakic eyes with RD and with PVD. So if it's a single hole, what is the choice? So these are different questions have been asked. As we can see, scleral buckling is topmost, and the second topmost is pneumoretinopexy. But yes, the vitrectomy is still there. Vitrectomy with encerclage is not so fairly common. And when we are talking about a phakic patient with superiotemporal single break or multiple breaks to talk about, in this case, vitrectomy goes high above than buckle, but yes, buckle is still there, and buckle plus vitrectomy is another option. In this PNR is not as well followed. So just to understand, these are phakic patients, phakic eyes. So right now, if there is a PVR grade B or less, and if it's a superior break, what to do? As we can see, vitrectomy is the topmost choice, and the scleral buckling is the second most, and the third most is vitrectomy with encerclage. But if it is anything above C, as you can see, vitrectomy or buccal vitrectomy is the choice, and only buccal completely goes out of the window. If it is inferior detachment and grade B or less, as we can see, only buccal is very, very minimal, but yes, buccal plus vitrectomy is the topmost. This is talking about phakic patients and PVD being present. And the last one where we have very severe grade C PVR and inferior detachment, as you can see, buccal plus vitrectomy or only vitrectomy. So the lesser the PVR and the detachment, either superior or inferior, guides as what we can see. The first part where there is a single hole, buccal PNR is still probably gaining a lot of traction over there. Fake it without a PVD. In this case, as we can see right now, vitrectomy is very, very less, but yes, buccal is a topmost choice. And if there is no PVD in this cases, as we can see that if there are multiple holes as well, people still want to do buccal. And yes, the second topmost would be vitrectomy. If it is superior break with less than BPV, PVR, if it's superior, as we can see, vitrectomy with gas, but buccal can still be tried in these cases. And if we talk about more than grade C PVR and superior, buccal plus vitrectomy, and vitrectomy is the topmost choice. Inferior, less than grade B, as we can see, only vitrectomy and vitrectomy with buccal, and more than C PVR with inferior, as we can see, only vitrectomy or vitrectomy with the encerclage. So fairly, very clearly understanding that if it's single break, buccal, and superior multiple breaks, again buccal or vitrectomy, but in rest of it, it's either vitrectomy or probably buccal and vitrectomy. Let's come to cases where there are intraocular lenses with detachment with PVD. As we can see, buccal plus vitrectomy in single cases is not as much, but only vitrectomy. PNR is there somewhere, but not as commonly done. Multiple holes, vitrectomy is the choice, and if it is grade B PVR with superior, vitrectomy. As you can see, if it is more than grade C, still PVR. Sorry. Okay. So if it's superior, again, buccal plus vitrectomy or vitrectomy. If it is inferior, as we can see, buccal plus vitrectomy or vitrectomy, inferior grade C and more, it's vitrectomy versus buccal plus vitrectomy or BB plus vitrectomy. So without PVD, more so, vitrectomy is the choice as what we can see in PCIOL. Buccal, only buccal is a less preferred choice. And buccal plus vitrectomy goes very high if there is inferior detachments, as you can see, and more higher the PVR, the higher is the choice. But otherwise, as you can see, if it is PCIOL, as Dr. Ashray was suggesting, this is again like a neck to neck kind of a presentation. It's like an individual preference whether you still want to do a buccal plus vitrectomy or not. Let's talk about the tamponade. So if there is a kind of a detachment which is grade B or less, so the blue ones are the grade B or less. As you can see, the gas is the topmost choice in cases with superior detachment. This is to talk about superior. And if it is grade B or C or more, as we can see, 1000 centistroke oil is the most commonest use. Let's see about how it is inferiorly. So as we can see, the gas is not a very good option chosen by a lot of our practicing ophthalmologists. So most common is oil, which is 1000, but yes, 5000 is also a choice which is being made by some of our colleagues.